want to pass urine, we don't get pain. So it's important to analyze the symptomatology in a patient with urinary calculi. You have to see whether, because depending on which part of the urinary tract the stone is in, you will have different types of pain. If it is in the renal, if it is in the kidney pelvis, you will have renal colics. They are deep-seated loin aches. They are not loin to groin pains. They are deep-seated. They are every now and then you get, right? So, and then when you have upper ureteric stones, they are upper, mid or lower, they will have loin to groin. But if it is VUJ or bladder, then you have strangulation. And hematuria will be associated with most of these patients. And bladder neck stone patients, in addition to that, might have features of lux also sometimes. But more of strangulation is the one that you get. But if it is a large bladder stone, you might have features of lux also. There is something getting stuck there. It's pretty much like benign prostatic hyperplasia obstructing the urine. Depending on the site of the stone, you have different types of symptoms. So you need to analyze these when the patients come. That's why you learn these things. That's why the physiology and anatomy combining together in the stone. That's why that knowledge is important. So what do you do for this kind of thing? What is the management? Your patient, no? Your patient. What do you do?
And I just stop it and do a X-ray KUB and UFR or the UFR to see microscopic hematuria and
Change your life.
and to confirm whether there is a final effect or not.
So UFR, if you have significant stones, most of these patients with ureteric stones sometimes will have a bit of pustule passing also, in addition to prevalence. So in that case, we will consider starting with urinary antiseptic on top of to use the medicine. So anything else? We will start. Yeah. So what is the name? Medical response Alpha 1 blocker. Anything else other than campsinosin that can be used for the same purpose? There's another alpha 1 blocker.
Cholinergic drug.
What's nifedipine?
Calcium channel.
Calcium channel blocker. So when you give these alpha 1 blockers or calcium channel blockers, what happens?
Relaxation of smooth muscles. Relaxation of smooth muscles.
You relax this. You relax the small muscle. So when you relax the small muscles, what happens? First thing you get is
Pain.
you get pain machine. Right? So damsulazic on top of additional lateral. The other activities will also have the analgesic effect. Then how does it stop? It facilitates the passage of food. That is what is presumed in addition to this analgesic effect because of this relaxation of smooth muscles, damsulazic or nifedipine, they will help propel the stone down. How does that happen? So when you release, relax the smooth muscles, obstruction gets released.
No, with the
That's
urine,
mechanism.
urine flow, it will get flushed out with the urine.
How?
With the urine produced.
Okay, so you have to hydrate these patients. That's why you always tell these patients, you forgot one thing in your management, hydrate. Okay? So, yeah, you are correct. You have to give 2 to 3 liters of fluid every day. You have to tell the patients, even if you feel thirsty or not, drink water. That's not my question. My question is, how would hamstring or liquidity, relaxing the small muscles in the brain, help in the process of propelling a stone down? Anybody can think and answer. Microscopic molecular level දැනගන්න ඕනේ manage action එක. If you think you can actually answer. Yes. Yeah. What's going on? ගෙදර Yeah? Anybody? So you can't. Now I have given the action of the drug, and I have given, I have set the end result of what is happening, and you can't connect the two. Huh?
When the relaxation process is
Yes.
the diameter, it can passes the
Diameter?
increases.
How?
That's we are relaxing.
How? That's what I'm. How does the diameter change?
It's a radial circumference. Smooth muscles, it's relaxer.
Okay.
When relaxing, because of the circumference, smooth muscle, it increase the diameter of the bladder neck.
Now I have already told smooth muscles are relaxed, so there is no peristalsis anymore. We prevent the peristalsis. When the smooth muscles relax, you don't get peristalsis. Then how? Then it just comes down. Huh?
Urine
Huh?
urine flow coming from the from the kidney level.
Yes.
Urine flush flow
out.
with high flow with
High. Ureteric urine high. Drop by drop urine in. That's not the reason that happens. මෙච්චර වෙලාව ගුගලනේ දුන්නේ see whether you guys can not gravity. Gravity helps a little. Just to work it out and කියන්න පුළුවන් කියලා. දැන් මොකද්ද වෙන්නේ? smooth muscle relax කරනවා, urine එකක් මෙහෙම තියෙනවා, ගලක් තියෙනවා, smooth muscle relax වෙලා urine උඩ ඉඳන් පහළට එනවා. දැන් මොකද්ද වෙන්නේ? ගල obstruct කරගෙන ඉන්නේ urine එක. මොකද්ද වෙන්නේ එතකොට? There will be a column of urine formed on top of the stone. There will be nothing down. එතන මොකද වෙන්නේ? මේ urine column එක නිසා urine එක මහත් වෙනවා. This is why they get hydroureter. This is why you get hydroureter in stones, and that is evident in the ultrasound scans. That is why we do an ultrasound scan to see whether there is evidence of hydronephrosis or hydroureter by a ureteric stone, because ultrasound scan is not sensitive to see ureteric stones. Because why? Not because of that. Especially when the ureteric stone is in the mid ureter or the lower ureter, because of the bubble loops on top of ureter is a retroperitoneal structure. Retroperitoneal structures are not properly seen. But presence of hydronephrosis you might be able to say, not the presence of the stone. So if there is hydronephrosis and the patient who gives a history of loin to groin pain, that is suggestive of presence of a stone. So you do an X-ray and see whether the stone is most of 90% of the stones will be seen in the X-ray, because they are radiolucent most of the time. So yes, that is why we do those two investigations. And then when you have hydronephrosis, hydroureter rather, a column of urine, it will increase the pressure within the ureter above the stone, and there is nothing under the stone. So there is a pressure gradient. High pressure, low pressure. When there is high pressure and low pressure, when there is a pressure gradient, always any object will try to move towards the low pressure. Right. So that is how the stone passes down. Not rocket science. It's simple understanding of day-to-day life things. මොකක් හරි දෙයක් abstract වෙලා බටේක ඒ බටේ relax වෙන්න අපි ඉඩ දීලා තියෙනවා නම් there will be relaxation and distension of that button above that obstruction. Because of that pressure, things will propel down. And now that we have relaxed smooth muscles, the propelling down of the stone will be smooth. It's a nice process. ඒක ලස්සනට පහළට වරනවා. pain free විදිහට පහළට යනවා. So that is the expected mechanism of medical expulsive therapy. This is what is presumed to happen. Nobody knows that this is how the එයාකට බලන්නේ නැහැ stone එක pass කරනවා කියලා. This is the theory. Right? Most of the stones which are less than 5 millimeters anyway will come down even without medical expulsive therapy. 95% of the stones which are less than 4 millimeters will pass spontaneously. You don't need to give anything. But the stones which are a little more than up to about 10 millimeters, you can try with medical expulsive therapy and see whether the stone passes down. And some studies have shown that actually they will pass spontaneously. Some studies have shown actually there is no effect by starting medical expulsive. So this is a controversial fact that still makes a debate between different urologists in our country and rest of the world also. But still people give tamsulosin or nifedipine when patients come with ureteric stones. It's part of the medical expulsive therapy is still considered to be part of the management. So what are the types of stones you know? The stones can taragi one is. Class at taragi one is. Huh? කතා කරන්නේ නැද්ද මේවා? කොහොම ඇක්ෂන් එක කතා කරන්නේ නැද්ද මෙඩිකල් එක්ස්පල්සිව් තෙරපි වල? Right, okay. So what are the types of stones you know? So how can you classify stones?
Radio frequency.
Is that the only way that you can classify stones? Stones can be classified according to their size, according to their size, according to radiological Hounsfield unit densities, and according to their chemical composition. That is how you answer when the question is asked. You don't blurt out and say calcium phosphate stones and calcium oxalate stones and screw white, ammonium, all that crap. If you say this basic classification, that will give you more marks than coming out with the term Indinavia stone. What is an Indinavia stone? Medical students, you know the rarest of things, but not the elephant in the room. You say these types of stones. So there is a stone called Indinavia. What stone type of stones? Some medical stones or medical drug stones. අපි බෙහෙත් ගන්නකොට බෙහෙත් නිසා stones හැදෙනවා. Ciprofloxacin and there are few drugs that are known to cause this problem. Indinavia is such a drug that is very famous to produce stones, ureteric stones. What is the characteristic feature of that stone? Almost all the stones in the world will be seen radiologically. That means by X-ray or a CT. If you can't CT, X-ray will show more than 90% of the stones. CT will show 99% of stones. Only 1% of stones, like one type of stones will not be seen in CT, and that is Indinavia stone. Right? And make a rare fact. You don't need to know this. Even if you know this, nobody gives a shit about it. But if you are asked to come out with a diagnosis, if you know this is the one that you will tell us. That should not be the case. You should always give the basic outline whenever a question is asked. What are the types of stones? I can go radiolucent, I can go radiopaque, I can go calcium stones. That's not what we like you to come out with. අර විදිහට කියලා ඉවරලා then you classify. Sorry, then you list down. So depending on the chemical composition, what is the commonest type of stone in the world? Huh? Calcium? Is it? Okay. So calcium oxalate. Anything else you know about calcium oxalate? What is the difference between the calcium oxalate? What are the types of calcium oxalate? There are two types of calcium oxalate. Calcium oxalate monohydrate and calcium oxalate dihydrate. Why is it important to know that? Any clinical importance for a surgeon to know that? Calcium oxalate monohydrate, you can't say that calcium oxalate monohydrate කියලා අපිට කියන්න බෑ chemical බලන්න නේද? But clinically surgery එක කරනකොට let's say bladder stone එකක් හරි ureteric stone එකක් හරි කඩන්න බලනවා කඩලා එළියට ගන්න බලනවා. Monohydrate stones are very difficult to break. Dihydrate stones, they break. They are very brittle. So that's how you know it's a monohydrate and dihydrate, because that's one of the common. What's the other common type of stone?
Sodium
Calcium phosphate stone. Calcium phosphate stone, they are also very common. What happens? What is true white? අහලවත් නැහැ. True white කියන වචන එකක් අහලා නැහැ. STRUVITE. Okay, read about what is true white. That is something you will be useful. ඒක තමයි true white කියලා අහලා නැහැ. Okay, you read what is true white and tell me what is true white. And then what is the Stackthorn calculus?
Calculus the urinary pelvis into the calcium system. Look like Stackthorn.
A Stackthorn calculus by definition is a stone that is formed in the renal pelvis that extends into either one or more of the major calyces. That is the answer. There's a definition for Stackthorn calculus. If there is no extension into a major calyx, you don't call it a Stackthorn. You have to have an extension into a major calyx. Most of the Stackthorn calculi in the world are considered to be true white. True white can be chemical composition of true white. Yes?
Phosphate.
Yes. Triple phosphate. Yes. So it is associated with infection. That's the other feature. And most of the countries in the world, this true white, Stackthorn calculi is true white. But in our country, apparently it's calcium phosphate. They have done a study in our country. There is a difference in that world values. You don't need to know that. That's all. So what you need to know is the clinical presentation and the management of these patients, because about 20% of your patients in casualty will be ureteric colics. Maybe about 10%, not 20%, or 10%. 1% of hospital admissions will be a ureteric colic. 1%. They can have hospital patient 100ක් ආවදී හැම පාටුවම මුළු ස්පිරිතාලෙම කියන සේරම පාටුවයි. එක patient කෙනෙක් ureteric colic එක. So it's that common. Every day you get so many ureteric colics. Management ඉතින් හරියට දැනගන්න ඕනේ. So what are the dietary factors that will increase the formation of ureteric stones or urinary stones or urinary stones? What will increase the risk and what will reduce the risk?
Reduce water intake.
Yes? Citrus will reduce the risk. While what will increase the risk? Alright. oxalate containing food will increase the risk of formation of stones. Why? There's a reason why citrate would reduce and why oxalate would increase.
Citrate.
Read about it. You read about why citrate reduces the formation of stones and why oxalate increases the risk of stone formation.
Citrate is water soluble. Oxalate is not water soluble.
Is that the reason? Water soluble no even is there oxalate containing what are oxalate containing food?
Tomato.
Tomato, yeah. Tomato has a lot of oxalates. pH difference. This mechanism why oxalate containing foods අපි ගත්තාම ඇයි අපේ calcium oxalate stone formation එක වැඩි වෙන්නේ කියලා. නෑ දන්නේ නැහැ. It reduces soluble oxalate soluble vitamin C reduces. Yeah, that's another mechanism now. I am asking about oxalate. Why oxalate containing food will increase the formation of stones? Read about it and tell me. And you have to tell me what are the other substances that will increase the risk of uric acid in the diet. There are a few things that will increase the risk and there are a few things that will reduce the risk. Red meat. Homework. Why is it? Is it important?
Yes.
Because you have to advise the patient on dietary habits. That's why it's important. So most of the things that are there, they are not extremely proven, but there is a trend. You take these kinds of food that will increase the risk of stone formation. You take these kinds of food that will reduce the risk of formation. You need to know a few things at least, because when you are sending the patients home, we tell these things to the patients and send them home. Because there is an entity called recurrent stone form. 50% of patients with stones will again develop a stone within a period of 5 years. Almost 90% or so will develop within 10 years or so. So these recurrent stone formers, you have to tell them to improve their diet. It's one of the ways of preventing stone formation. Then what are the ways of managing ureteric stones? Ureteric stones can
You can do intervention or
okay, so there is always your answer should be a little better than that. The management first depends on the site of the stone, right? Because some stones will actually require intervention depending on the site. So it depends on the site of the stone, and then of course it also depends on other factors of the stone as well as patient characteristics. That's the first step. Principally speaking, you have conservative management and intervention. Conservative management is pain management and medical expulsive therapy, but that is not going to work for renal stones. Because renal stones, medical expulsive therapy, not bladder, it won't work. So it works for ureteric. So then you have interventions. So what are the interventions you do for stones? Again, it depends on where the stone is, right? So if it is renal, what are the types of surgical procedures you know you have minimally invasive procedures and open procedures. Minimally invasive procedures could be okay, extracorporeal shockwave lithotripsy or ESWL. Then less invasive procedures, CCML, and endourological procedures. What are the endourological procedures that you can do for the kidney stone? A stone in the ureteric pelvis, let's say. Huh? Kidney pelvis. You do retrograde RIRS. RIRS is the term that we use for retrograde. See what RIRS stands for. RIRS කියලා කියන්නේ flexible ureteric stone එකක් pelvis එකට ඇවලි වෙලා pelvis එකේ තියෙන stones laser lithotripsy කරලා අයින් කරන එකට තමයි කියන්නේ RIRS. That's very interesting. So that is for renal stones. You have PCNL, RIRS, ESWL. Those are less invasive procedures. ESWL is minimally invasive. And then you have open surgical procedure or invasive surgical procedure. That will basically nephrolectomy and pyrolectomy. Right? Pyrolectomy is not nephrolectomy. ESWL, what do you know about ESWL? What happens in ESWL? Huh? Yes, so that's what it does, right? So it sends a wave, an ultrasonic wave, kind of an energy wave, not ultrasonic per se, but kind of an energy wave that breaks the stones to pieces, right? So there are several generations of ESWL machines. Now I think we have the third generation of something. Back in the day, people used to put the patient in a water bath and then with these ESWL because you have to have a coupling mechanism between the waves and the human body. So can every stone be managed with ESWL in the kidney? So what are the stones that can be managed with ESWL? Okay, good. So when the density is less than 1000 pounds feet, okay, they are the subjects available. Anything else? Is the generally size of the stone? If the stone is less than 2 centimeters, we consider stones of ESWL. More than that, ESWL is not going to be effective. Large stones you can't break with ESWL. So you have to have density, you have to have good size. And then anything else? Patient factors, good. So you have, make a better again. So when you ask questions, again the answer is there will be patient factors that will be determining this as well as stone factors. Patient factors, obese patients, they are not very good for ESWL because you have to have the skin to stone distance should be minimal. It should be very, I can't remember the value, but if you have a very thick patient, bulky patient with a thick skin to stone distance, that's not going to be effective. Then number 2, stone factor, size of the stone, density of the stone, and then anything else, location of the stone. Pahala India ke තියෙනවානේ upper calyces, mid calyces and lower calyces. Lower calyces එකේ තියෙන stone එක break කරන්න අමාරුයි. Upper and mid calyces stones you can break with these shock waves and get them down. Lower calyces එක break කරාට ඒවා එළියට එන්නේ නැහැ නේ. එහෙම එන්නේ නැහැ. So that's why Upper and mid calyceal stones less than 2 centimeter with a Hounsfield unit of less than 1000 are amenable to ESW. It is to be lower ureteric, lower calyceal stones, then the size should be less than 1 centimeter, and then the lower calyx should have a diameter of more than 10 millimeters. Lower calyx pelvis diameter more than 10 millimeters. Length of the lower calyx should be very less than 7 millimeters or something. So you don't need to remember the figures. Lower calyx stone and lower calyx anatomically favorable with and then the angle between the lower calyx and the pelvis. Lower calyx pelvis lower calyx lower calyx ureteric angle more than 70 degrees. මෙහෙම angle එකක් තියෙනවා. මෙහෙම angle එකක් තියෙනවා. මෙහෙම තියෙනවද in stone. මෙහෙම තියෙනවද stone එක. So things like that matter. So it depends on the location of the stone, the size of the stone, the density of the stone, as well as patient factors. If you have all these only, ESW will be effective. Anything other than the ureteric renal stones, ESW can be effective. Pancreatic stones, yes. Pancreatic stones. You have seen in this unit how many patients we refer to ESW with paralysis. Pancreatic stones. And then renal stones, pancreatic stones. Anything else? Upper ureteric stones. Renal stones, upper ureteric stones. Ureteric udahariya ESW is amenable. But ureteric madahariya, pahalhariya, ESW you can't work because of the other structures. You will be damaging the surrounding structures if you do keep ESW. So upper ureteric stones, they are amenable to ESW to a certain extent. But those stones should be less than 1 centimeter. You can't have big stones. So what commonly happens after ESW? Stones break down and then they will start passing down the urine. So you have to give analgesics to the patient. You have to give amsulosine to the patient to propel the stones down, because now you have effectively made a pelvic stone to a ureteric stone. Patient will have pain. Patients initially had renal deep-seated loin neck, but now you are having ureteric colics. So you have to tell the patient that you are going to have this problem for some time. You will be having hematuria for some time, and you have to take analgesics and amsulosine. Some patients, what happens after ESW? What is the position of stones? They get stagnated in the ureter like a Steinstrasse Steinstrasse, it's a German term or something. Steinstrasse, that's how you pronounce it. Popple stones, never the appearance, stack of stones, and then Steinstrasse. So you get that condition after ESW. You have to warn the patient if the patient is undergoing ESW. These are things you should tell the patients. Clinically important ureteric stones. And then ureteric stones. How do you manage? Again, conservation and intervention. Interventions, you have minimally invasive procedures and open or laparoscopic surgical procedures. Minimally invasive procedures would be endourological procedures. You don't do PCA for ureteric. Endourological, so ureteroscopy, URSI, laser lithotripsy or IP, intermittent pneumatic lithotripsy. So laser lithotripsy is using a laser, we break the stones down. Intermittent pneumatic lithotripsy, we use the force of air. Pneumatic power. Alarm of air, that cannot be air column strength, color footprint. It's called IPS. So lithotripsy. If you don't know what happens in IPS, doesn't matter, but at least remember the term lithotripsy. It could be laser or mechanical. Right? So we have endourological procedures. And then open surgical procedure. What is the procedure? You are being? Huh? What is that? Ureter or lithodoc? Ureter lithodoc. Ureter lithodoc. And then you have bladder stone. What can you do for bladder stone? How do you manage bladder stone? Most of them should be managed by some intervention. Bladder stones, some small ones they can pass. You can have two types of bladder stones. De novo bladder stones, stones formed in the bladder. That happens in neurogenic bladders, when the bladder is not functioning. Or stones coming from up, getting stuck in the bladder. Right? So if you have bladder neck stones which cause significant pain, like this patient usually, but it's like bladder neck stone, you have to remove them. So again, you have cystoscopic procedures or endourological procedures we call it, or open surgical procedure. So cystoscopic procedure, what is it? Cystolithopaxy. All are in the midterms. Yeah? Hope this much. Cystolithopaxy. That is, you pass a device into the bladder and break the stones into small particles and take them out. යන්නේ ureter urology theater sessions වලට යන්නේ නැද්ද theater එකට දැකලා නැද්ද අර එලික්ස් එකකින් එලික්කිමැකුවේට කියලා දැකලා නැද්ද එලික්කිමැකුවේට කියලා theater එකේ ඔය exam එකේදී දීලා ඉවරලා හොදින් what is this කියලා school theater එකට ගිහලා නැද්ද that is something historically every medical student would remember if you go to the theater and see urological case, especially URPs, and they use what is called an Colic evacuator. Sagaraya, although like a and then the that cut the hand, that can have in
when I was there, there's only prostatic.
Open prostatectomy. Amar Dasar take a list again. हम सर्जरी में करना हमें एक में एक दिया
Patient was there.
किसी ने दिया ना लेकिन
Others post.
prostatectomy करना है ना open right so you break the stone and take it out. Where is it? I had a liquid exam here. Then you have open surgery, cystolithopaxy, vesicolithopaxy, vesicolithopaxy. Open color, stone evacuate. If the stone is very large, you do that. So that's what bladder stones, urethral stones also. Sometimes you can milk it out. It is at the tip of the urethra. You might be able to pass a small instrument and take it out or milk it out. If it is high up in the urethra, pass a catheter and get the stone into the bladder, and then later on go and take it by cystolithopaxy or some other. Our management हमारे क्यों नहीं ये यूरोथेरेसिस करा गया है वो ओपन नहीं में उड़ाई को सेट एक बार करा गया. It's a very important topic, ना? करा दे अंदर करा नहीं आगे नहीं रहे क्लास कर ले बैठे तो नहीं पता नहीं जानने से आगे क्लास वगैरह करना है you have told everything how the class करे लंगर से करे पटंगा
सागर सर्कल
the others.
මොකද ඒද කරේ?
I mean,
ඔයගොල්ලෝ යූරෝ ටොපික්ස් ටික කවර් කරගන්න සාකරට කියලා. Material, stones, lux, very important topics. All are long cases, huh? In the exam. Every day you will get one euro case. Yeah, cases සාධාරණ cases පහක් දානවනේ long cases. මේක තමයි දාන්නේ. 15. එතකොට cases 5 හරි 6 හරි අනිවාර්යෙන් එකක් euro case එකක් වැටෙනවා. So euro is very important.